Hello, and thank you for tuning in to the Alter Ego podcast, produced and recorded right here at the Butler Eagle on West Wayne Street in Butler, Pennsylvania. I'm your host and producer, Laura Crego. Make sure to click subscribe on the Butler Eagle YouTube channel to follow along. And if you're listening on your favorite podcast platform, please take a moment to rate and review. It really helps us out. And now, on to today's episode. Joining me today is Karin Byers, MD, certified in infectious disease by the American Board of Internal Medicine. Dr. Byers is a professor of medicine at the University of Pittsburgh School of Medicine. She received her medical degree and residency at the Temple University School of Medicine, and she completed her fellowship at the University of Virginia. She is affiliated with UPMC Presbyterian and UPMC McGee Women's Hospital. Karin, welcome to Alter Ego.
Thank you. I'm glad to be here.
I know this was kind of a last minute thing. So Karin and I met at a restaurant I used to waitress at. Well, technically, I actually have been picking up some shifts recently. Have I told you that?
No, I'll have to start looking for you.
Yeah, just, it's interesting when people know that you're picking up extra work. I think we can all attest to that life is expensive right now. And in the last year, it's coming up on a year, I have acquired some extra bills from a car accident that I had last summer, and having a car payment and all of the things that kind of came with that, it's left me a little tight, right? So because I am a very independent single woman, I was like, I'm going to see if I can get some extra work for the summer and then see how that goes into the fall perhaps. And I knew that they were looking for help. And so I reached out to them, and obviously, they didn't have to train me. I did a few shifts where I was just working in the kitchen like expediter, getting the food out, running food. And Jared's going to give me some serving shifts on some weekends. He just has some shifts where he needs people because everyone's taking vacations and can't complain, right? So
that's great. I will look forward to seeing you again.
Yeah, you and Bob will come in one day, and I'll be like, hey, I might be your server. Who knows?
That will be a pleasant surprise.
Yes, it would. So. And I don't even know how we started talking, right? Do you remember? I mean, I know I'd had you at my table, but
I don't know, because we would go there so often, and we still do, that everyone starts to become familiar. And so I kind of feel like I always knew who you were.
Yep. Yeah. And you tend to sit, you will both come in and sit at the bar, and you have your dinner. The bar is a lovely place to sit, especially if you don't have a reservation. It's nice, it's casual, it's laid back. And yeah, I think that's just it. You are regulars, and we love to get to know our regulars there, and we appreciate, the support. Obviously, I think it's when people ask what the best Italian restaurant is in Butler County, I'm like, Della Terra, hands down.
I would agree with you.
Hands down. And that's
tell everybody to go there, and then I worry that we won't have seats. But
true.
We love it there.
I feel like you guys need like plaques, like these are your seats. Do you like to sit at a specific spot? Or, I mean, obviously if you go in and there's only something open, but if you were to choose, if the bar was open, is there a spot that you and Bob tend to sit at?
I think if it's wide open, we sit in the middle, and then we can talk to whoever's behind the bar. And because we know everyone that works there. And so I think that it feels like a very friendly environment. But I think our second choice would be on the far end, where we can watch everyone making pizzas, and it's, dinner and a show.
Mm-hmm.
So
yeah.
I think those are two spots.
Yeah, I love that. Infectious disease, when you told me that was what you do, now you also are a general practitioner in medicine, correct? Like you have patients and...
So all I do right now is infectious diseases. So the way that the training works is after medical school, you pick your residency. And so I picked internal medicine because that's kind of what really appealed to me. And I liked the thinking part of practicing medicine. And then during residency, then I decided to do a fellowship. So residency is 3 years for internal medicine. And then I decided to do a fellowship to study infectious diseases. And that's really where my career is now, is just doing infectious diseases. So most of the infectious diseases training programs are about 2 years. At the University of Virginia, they asked everyone to do 3 years. And that allows for more time to do research. So I was there for 3 years then. And that's all I do now is infectious diseases.
I don't even know how to refer to doctors when I get down to brass tacks. It's like we go to doctors when we're like at our worst, right? We need answers, and there has to be a lot of pressure for you What would you say was probably one of the first cases that you ever came across in something that you genuinely didn't know what was going on? Have you had
Um,
a case like that?
Yeah, I think we all have cases like that. And I think part of what I like about this field is that it really is problem solving. And so if someone has a fever and you don't know why, you run through, is it something infectious? Is it something that's autoimmune? Is it actually something that is certain kinds of cancers that can cause fevers? So just trying to sort through what all of those different things are. And sometimes really time will kind of tell what that is. Um, but I think then part of what we do in our field is we try to figure out, maybe did somebody have some unusual exposure. So if we can't figure something out, we'll go into, where did you travel? What are your hobbies? What pets do you have? And sometimes that will be the clue to figuring out what somebody has. So I think that part makes it really interesting.
Yeah, that is interesting to me. I think for me as a non medical person, I always feel, can we get blood work done? Would you say sometimes that is a go to, especially if something's looking like it could be many different things?
Yeah, so sometimes we can find the answer through blood work, and sometimes we can't. And it may be a matter of just thinking about which tests to order. So if you're looking for something, if there's something very specific that you need to order, you might not pick that up on some routine blood work, but sometimes you'll still get a clue. So if somebody has a chronic infection, often they'll become a little bit anemic while their body is working on fighting that off. So we'll sometimes see that even though we don't know what it is yet, that anemia might be a clue to me that someone has, that what is going on could be an infectious, a chronic infectious process, or
Mm-hmm.
the white cell count is usually elevated with infections. So it might at least give me a clue to, as to what I'm looking for.
When it comes to, infectious diseases that you treat, what would you say are some of the top ones that you do come across in your profession?
I think some of them would be things like complicated pneumonias. So if
Mm.
you have pneumonia, which is an infection of the lungs, and you go to your doctor, they'll usually know which antibiotics are likely to work. And the hard part with pneumonia is that even in the best studies, when you get sputum cultures and you do blood work and you can even do sampling from the lungs, we often don't prove which organism is causing it, but we do have a pretty good idea of what the most common organisms are. So everyone kind of knows which antibiotics to use typically for someone with pneumonia. But if someone isn't getting better, or if they're in the hospital and they've got a pneumonia that they acquired when they're in the hospital, then we start to think about more unusual organisms. And so we're often involved in trying to figure out which antibiotics to use, especially if we grow a bacteria that's resistant to a lot of the standard antibiotics, then trying to figure out what other options do we have.
Okay.
So that would be one of the common ones. We also see, I mean, a whole range of things. So I think another one would be if people have wound infections. So, and
Mm.
most surgical procedures, you don't get infections, or we wouldn't do all the surgeries that we do. So I have this outsized view that every surgery results in an infection because those are the patients that I see. I don't see all the patients that do really well, which is most of them. So then trying to again figure out which organisms are likely to be involved, how deep is the infection, what can we treat it with antibiotics alone? Do we need to drain something? So trying to sort those things out and then figure out how long to treat those kinds of infections.
I think one thing with, doctors, it's like humanizing doctors because when it comes down to what you're doing, you are there to find the answers, right, to treat the patient and make them healthy again. I mean, I'd say if that was like the simplest way to explain it, for you, have you ever had a moment where you felt emotionally effective, whether it was positively or negatively, by someone's, refusal or acceptance of what you're sort of telling them? A lot of times it could come down to lifestyle changes, right? Have you ever come across that with what you do with infectious disease?
I would say not so much with lifestyle changes, but I think that some of the things that I've encountered that have been, I mean, there are the things where you get emotionally involved because there are patients that you get to be very close to, especially um, early in the HIV era.
Mm.
That when I was doing my fellowship, the first really good drugs for treating HIV came out. And I had some patients right around that cusp of when the newer drugs, the protease inhibitors, came out. One that I was very close to who passed away around that time, and that person was very secretive about their diagnosis, and did not want their family to know. And it was someone that I really had gotten to know very well over several years. And so, I think there's kind of an emotional part there when you see that. I've had a number of other patients over the years that I've really gotten to know well and cared a lot about. So there's that emotional part there. But I think when it comes to the reactions we get from patients, and I might not be answering your question quite the way you asked it, but I remember one time walking into a patient's room and I'd never met this person, and they started yelling at me. And I was, I was a little bit surprised, and I thought, let me figure out what's going on here. So, in talking to this person, they needed a procedure, and it would be a life-altering procedure, but they would need that to survive. And she was very afraid of this procedure. And so, when I asked her if she'd ever known someone that had had that procedure before, apparently this her sister had died while undergoing the same surgery that was being recommended for her. And I think I can say that without patient like without being an issue with patient confidentiality. But I think that conversation turned around completely from somebody like yelling at me and angry at me
Mm-hmm.
to really being scared, and that was what came out of that conversation. And so I think that happens sometimes, and
Mm-hmm.
I'm often surprised at how often I will see somebody in the hospital, and when they come back to see me in follow up, they'll actually apologize for their behavior in the hospital. And I won't have thought it was bad at all. But when they're in the hospital, you lose so much of your ability to control your surroundings. So, you're in a hospital bed. You might have to call someone if you even want to go to the bathroom. You
Mm-hmm.
have limited food choices. People are coming in to wake you up to get your vital signs and to draw your blood early in the morning. And you just lose all autonomy there. And you're wearing those, hospital gowns that nobody likes. And so I think that I always expect kind of the worst out of people when they're in that situation. And I'm often pleasantly surprised just by humanity and the people that I encounter and how many people are really gracious through very difficult situations. And not everybody, of course, but I think I tend to be an optimist, but it tends to restore my faith in humanity when I see people in that setting.
Well, that's a very relatable situation. I think anyone who has experienced something traumatic like that, and then to almost feel as if the same thing could happen to them, that has to be, it's an understanding. And that's why I think you're so wonderful for what you do, because you do have that sensitive sort of humanizing side to you. And I'm not saying all doctors don't, but I have encountered situations personally where I felt, and it only happened one time when I lived in New York. I had a situation with a male doctor where I felt that I was being judged because I was a woman based off of what I was going through. And it was, oh, well, it's probably just hormones, and it's probably just, maybe you just need to take some time to relax and, self-care. And I was thinking, that is not what's happening here. Like, that's not what just happened to me. I had a full-blown panic attack at a job, and I'd never experienced anything like that before. And when I was explaining to him what happened, I mean, everything got really bright. And I remember feeling like I couldn't really understand what anyone was saying. Everything kind of seemed like foggy almost in a way. And I thought I was going to pass out. It was very strange. It was a very strange situation. And because I come from a family with like heart disease, immediately my brain went to, okay, is there something wrong? Like, I feel like there's something wrong with my body.
Yeah,
So
that sounds really scary.
it was scary. And I was in my 20s. So I was also sort of still at this age where, a lot of people, I've seen a lot of people get married at very young ages and take on responsibilities. And I'm like, I don't know how they did that, And as you learn about how our brains develop, I'm like, my brain wasn't even fully developed at this point when this was happening to me. I didn't even have my frontal lobe. I couldn't really, there was a lot of things that I was struggling with at that point in my life, and I didn't really know who I was exactly. So with that happening at the same time, it was distressing to go to a hospital, and not that I needed to be coddled. I just needed to be listened to and heard.
Yeah.
And I wanted some sort of comfort in knowing that I didn't have anything to worry about. I wasn't going to have a heart attack, or I didn't have a brain aneurysm. Do you know what I mean? I didn't know what was going on. I genuinely felt like something was wrong.
Yeah, and it's not that hard to kind of walk through. These are the dangerous things, and this is why I don't think you have these things. And I think that can be a fairly simple conversation if you can explain if this is what was going on, this is what I would be seeing right now. And I think having just the ability to reassure somebody is sometimes really important.
Well, I think reflecting back on that and learning as an adult that I don't know what was going on that day in the emergency room, what was going on with him, if something had, not to dismiss like how I should have been treated, but I do think that I've become a little bit more compassionate when it comes to, hey, that was not personal. Although it came across that way, there's definitely something else going on there. But in that instance, it's like, but it's kind of your job. Like you're the doctor and I'm the one who's freaking out and crying. And you're telling me that you think it's emotions and you're asking me if I'm on birth control and things that I was like, well, this feels a little inappropriate and insensitive in a way where I was like, you're trying to diminish what I'm experiencing. So not to get off on a tangent on that, but it's not easy what you do. Is there any infectious disease today that you've dealt with that you think is misunderstood and why it's misunderstood?
Now that's a great question. I think there are some, I think, well, one area where I think sometimes it's hard is just when you're looking at diagnostic testing. And I don't know if this will completely answer your question, but I think that everyone assumes that a test is positive or negative, and the answer is yes or no. And we've
Yeah,
got
we
some
do.
tests that like will pick up, maybe 80% of the people that have this disease, but maybe it's not a perfect test. And we've got other tests for some things, like one of them is Lyme disease, which is, I think, something people think about a lot. And it's
Hmm.
a very complicated test because it's an antibody test, which means if you were just bitten by a tick, a couple of days ago, the tick was on your skin, it was embedded, and you acquired Lyme disease, and you're now getting a rash, a bullseye rash. If I test you for Lyme disease, it will come back negative, even though you have Lyme disease, because your body hasn't had time to make antibodies yet.
Okay.
So if you test too soon, you'll actually miss the diagnosis. And then the other
Mm.
complicated part of the test is that it's the screening test is designed to make sure it doesn't miss anybody unless it's done too soon. And so it will pick up a lot of people that don't have Lyme disease with the screening test.
Mm-hmm.
And then it's backed up with a confirmatory test. And then the confirmatory test is really a matter of counting what are called bands. So because some people will have some proteins that maybe they've reacted to, so they might have one or two bands, but you need to have a certain number of bands for that to be considered a positive test. So that's just confusing, um,
Yes.
and and we will have physicians that are really smart people that, and this isn't what they do every day, and they'll be like, they'll ask me, is this a positive test? Does this person have Lyme disease based on these results?
Mm-hmm.
And usually you need to know more about like the timing of when it was done and that sort of thing. But that's one area where I think there's a lot of confusion, even sometimes within the medical community.
Most of the people that I interact with when we talk about like if we're sick or this or that and a Z pack and antibiotics and all that, I haven't really had too many conversations with anyone that's like resistant to antibiotics, but
Mm-hmm.
I know that it exists. Do you
Yeah.
do you feel like there is a rise in antibiotic resistance and like if so, has that changed your approach to treatment?
We definitely see that. And I think probably more so in the hospital setting because that's where we're actually getting cultures. So if
Mm,
you're an outpatient and you're sick with something, most of the time we don't get cultures and you're treated for whatever it is with a course of antibiotics. And there's been a real interest in trying to figure out when is something viral and you really don't need antibiotics because
mhm,
we don't want to expose you to more antibiotics, in part because then you can get resistant bacteria. You may have an allergic reaction to the antibiotic. If we kill off a lot of your normal gut bacteria, you might get this thing called C. diff. So we do worry about that.
mhm,
In the hospital setting, we see a lot more resistant organisms. And I've definitely seen that list of resistant organisms grow and grow as I've been in infectious diseases. And we're having a hard time keeping up with that with newer antibiotics because
mm,
if you were a drug manufacturer and you're going to make a new drug, you would want to treat something like high blood pressure, where people will take that drug every day for years. And when it comes to treating resistant bacterial infections, somebody might get that antibiotic for a week. And
mhm,
so there's a lot less interest in trying to develop some of those drugs. And some of the things we do in the hospital setting are we're really trying to understand what is the best way to use the antibiotics and how long do we really need to treat things, because most of the time when guidelines came out for how long to treat something, we knew if you treated at least a certain period of time, everyone seemed to get better. And
mm.
so we would give these really long courses sometimes, and we're developing, or there's been a lot of emerging data that suggests that perhaps a much shorter course is actually fine for many infections. So we're actually shifting a little bit over to shorter courses of antibiotics for many things.
In your career, how often, if you have traveled, like have you traveled to other countries and met with doctors in other countries to talk about trends that you might be noticing? And is there a difference in diseases that might be happening in, let's say, Europe and then here in North America that you've noticed?
So most of my travel is for fun, not professionally.
Okay. Okay. That's good
But
too. Yeah.
we had, when Bob and I were in Norway, and we met this family, and one of them was a nurse in one of the local emergency rooms, and we were talking about how we treated meningitis in the United States and how they were treating it there. And we were using much broader antibiotics in the US because of the bacteria being much more resistant.
Okay.
And there is a difference in terms of resistance patterns that largely relates to how often antibiotics are used in those communities or in those societies. And if people can buy antibiotics over the counter, we see a lot more resistance than if they are a little bit more restricted.
So when it comes to a lot of the chemicals that we are exposed to, and I think at this point we've been exposed for how long? I've been exposed for over 4 decades to who knows what. Does that also come into play when you are, whether it's researching infectious disease or recognizing new diseases or how these are evolving? Does any of that come into play with it?
I don't know that I think as much about like the chemicals that people are exposed to. I was thinking when you're asking about, I was thinking more about kind of geography and infectious diseases. And I think one of the things that was interesting is when I moved to Pittsburgh in 1997, I'm going to go back to Lyme disease. I was told that there's no Lyme disease in southwestern Pennsylvania.
Oh, okay.
We are now the hotbed of the country for Lyme disease. And part of that was that where it was first recognized in Lyme, Connecticut, and really took some time to spread geographically. So now we're a hotbed of Lyme disease. But if you went back just over 20 years, there was very little Lyme disease in southwestern Pennsylvania. So we already had the tests for it. We already knew what it was, but it was very rare here, and now it's quite common.
Why do you think it has grown in western Pennsylvania? Can you speak to that at all? Why Lyme disease? Is it because of our deer population? What is it?
I'm assuming it's probably more than our deer population because we already had the deer here before it got here. So I would imagine that it was just been, if it was the first time that there was kind of a large number of infected, it'll go back and forth between like mice and deer, and so I would imagine that there was enough of it in those populations in one area that as those animals were moving, it was spreading it to other areas.
Okay. Yeah, it's just, it's so fascinating to me with something like that, because the only way to contract Lyme disease is through ticks, correct? Or no?
I guess you could theoretically get it maybe through a blood transfusion or something like that, but we basically think it's through tick bites. And the problem with the ticks that carry Lyme disease is they're really tiny. So you might not know that you have a tick on you. So the really big ticks don't carry it, but the ones that do, you might look on your arm and think you've got a freckle there or something, and it's actually the tick that carries Lyme disease. And then it needs to be attached for several days before it's able to actually transmit that infection.
Okay.
So if it's not engorged, then it probably hasn't transmitted it.
Okay. And it would be engorged, correct?
Correct, but that's not the only disease that's carried by ticks. So we also worry about things. Another one that we see in this area a lot is something called anaplasma. So there are anaplasma and ehrlichia, which can be carried by the same ticks. And then the other thing would be babesia, would be another infection that's carried by those same ticks. So it's not just one disease. And those are kind of the local things that are carried by our ticks in southwestern Pennsylvania.
Mm-hmm. So I want to go back to 2020. Well, probably the end of 2019, right? Because I do believe that, and I could be incorrect in this, was it that the first outbreak of COVID was in China? Was it the end of 2019? Was it like November-ish of that year was when they noticed?
It was around the end of 2019, which is why we call it
COVID-19. Okay. Yeah. I'm pretty sure that I did know that. What, whenever we're talking about potential, outbreaks, what early signs do you look for when it comes to something like that? Whenever that came up, for instance, in China, were you sort of, and anyone else that you work with in infectious disease, were you kind of on a high alert, like, this could be something?
I think people in public health were very quickly on high alert, and anytime you start to see people that are dying from a new from an unknown reason, then you start to figure out what is the cause of that, and it takes a while usually to find a new disease and to figure out what it is and to learn about it, and then to try to develop things to treat it and control it. So, um, I was actually giving a lecture in the Graduate School of Health that January. And at the end of the lecture, the person who runs the course said to the whole class, "Now, this thing that you're hearing about in China, this coronavirus infection there, this is going to be a big deal." And at the time, everyone didn't know much about it,
Mm-hmm.
and it was very prescient that very soon we were going to be seeing this worldwide because it spread very quickly around the world.
Why do you think so many people didn't take it as seriously as it was at first? Because we're so evolved, or?
I think it depends on who you talk to in terms of how seriously they took it. And I think the one hard issue with COVID is that we've all had different experiences. So,
Mm-hmm.
working in the hospital setting, I was seeing people that were very sick with this. And I think among the people that I know, I don't know of anyone that didn't have a friend or family member that had died from COVID. So
Mm-hmm.
in my world, it seems like it's something that's very personal and very real.
Mm-hmm.
But if I lived in a remote area and I'd not seen anyone that had had a bad outcome, I think I might have a very different perception of the disease.
Yeah. Well, I think often as I don't know how I want to refer to myself here. Because I'm trying to think of how I can distinguish like all of the experience and the education that, doctors such as yourself have and the experience and understanding of things that I don't understand. All I know is that I trust I trust that if doctors and medical professionals and scientists are saying we need to take this seriously, this is how we are as of right now. Our understanding is that this is how it is transmitted. So, in order to contain it, we have to all sort of
Yeah.
quarantining. Thank you. Quarantine is the word that I was looking for. And I lived in Boston at the time. So, I was in this city, like I lived in the city and I just remember thinking, oh, wow, this feels very like War of the Worlds esque, because you're inside and you're looking outside and there's nothing happening. There's not cars really. I barely even saw cars, even living where I was in the South End. And to me, I just have always, my mom worked in the medical field. I've always just trusted that information. And I don't think that we're ever going to get to a place where we're all going to agree. I don't think I really don't. As hopeful as I might want to be that we can understand and appreciate each other and accept, there's such a resistance to even the vaccination process, and the history of vaccines goes back to what is the Spanish flu? Was that the first time that?
Actually, long before that. So
Okay.
the first vaccines were really that we people were kind of recognized as being the first real attempt at vaccination was actually with smallpox. And
Mm-hmm.
even before Edward Jenner, who was kind of recognized as the first person to develop a vaccine, even before he did that, there were many societies that tried to find ways to cure smallpox. And the common way of doing that was to actually try to give people small amounts of the smallpox virus, like a small enough amount that you wouldn't hopefully get sick, but some people did,
Mm-hmm.
and to try to develop some immunity to it. So the first recognized use of vaccines was really that at that point smallpox was very deadly. So about 1 in 3 people who got smallpox would die of it, and
Oh.
so it was a bad disease, and people were obviously very fearful of this disease. And there it was recognized at one point that milkmaids who were taking care of cows who often carried cowpox, it turned out they seemed to be protected from getting smallpox. And so it was later thought that perhaps the cowpox, which causes a much milder disease and is not usually a deadly disease, that perhaps that could be used as a way of preventing smallpox. So Edward Jenner gave a child, basically inoculated him with cowpox, and then he was exposed to smallpox and never got sick with that. So that's kind of the beginning of how vaccines started. And that same kind of idea for vaccines, there are a number of different ways we make vaccines now,
Mm-hmm.
but one of them is with something that's basically a safer kind of way of exposing someone to something similar to the infection you're trying to prevent and having your body make some immunity to that So then when you're exposed to the more dangerous thing, your body already kind of knows how to fight it off. So your immune system is primed to fight it off.
Okay. It's very fascinating to me. And I think obviously I had never experienced anything like that. A lot of us haven't experienced being in a pandemic, being quarantined, and then essentially being the first to have this vaccination. But if you look back on history, like you just explained to us, it's there's there's always a chance of risk. Is there a difference in how, I mean, obviously everybody responds differently. I know when I had the COVID vaccine, it was two shot. Was it two shots the first time? I think it was like one, and then you got a second one at a certain point. And I remember, I think it was my first one. It was the day after. I felt like I'd been hit by a Mack truck. I just felt completely knocked out. I couldn't get out of bed. And then the day after that, I was started to feel a little bit better. It took me about 2 days, I'd say, to feel like, oh wow. And just that little bit right there deters people. And it's like, but I mean, my dog has responded that way to his vaccinations, to even like heartworm. I did a flea, tick, and all in one thing one time for him. And he's so little, he just didn't handle it as well. He was knocked out for a good day. And I was worried, but it was just a lot on his system and he needed time to rest, which is typically the best medicine when you are sick, especially if you're on antibiotics. It's like rest, sleep, rest, fluids, rest, rest, rest.
Yeah,
So,
and let your body kind of do its own thing. But I was going to say, when you're talking about how people responded to the vaccines, like when I did fine with the first one. With the
mhm,
second dose, I felt really under the weather for about 48 hours afterwards.
mhm.
And yet my husband felt fine with all of his vaccines. And every time I get a booster now, I always try to make sure I get it on a Friday so that
Yes.
I won't be at work when I'm feeling miserable for the next 2 days, because I will get high fevers, I'll have shaking chills, and I'll
Mhm.
feel, really miserable. But I think that because I'm working around people that are sick, and
Mhm.
I may be exposed to, and I'm also working on people that not just sick with infectious diseases, but who maybe don't have a healthy immune system. And
Mhm.
so I think from my perspective, part of my duty is to make sure I'm not bringing anything to them and to do everything I can to try to prevent that.
Well, thank you for that because that's what you want to hear, and I know that it was a very chaotic time. I feel like a lot happened very quickly. It's like a sword and scale. You're weighing the options. It's like, okay, well, you could get the vaccination, right? You might have some side effects, but ultimately it's going to protect you. The goal is that, the percentage is high that it's going to protect you from getting this and dying from this, right? But there's never any guarantee really. So, let's going back to infectious disease, whenever you recognize that something is contagious, and if so, like when something first comes out, like what precautions do you take? And you just spoke to that. I mean, for you, you are making sure that you are being aware of the people that you're taking care of. Like you're almost putting them ahead of yourself in a way, but you're trusting the science too.
Yeah. And I think, when there's something that's brand new and we don't know much about it, the hard part is that even it took time to figure out like how it spread, how easily it spread.
Mm-hmm.
And so the typical response will be to try to isolate people with something with an unknown contagious disease. And by isolate them, meaning in a pretty aggressive way. So like, covering you're protecting your eyes, using, excellent face masks. So like the ones that will kind of block most small particles, gowns and gloves, all those kinds of things that we will wear, and sometimes even more aggressive kind of measures until we know something about what that disease is. And we know that we will see more pandemics of some sort or another again. There's typically, even just with influenza, there are about 3 pandemics a century, and some of them are really severe, like when you mentioned the Spanish flu. That's the one that everybody thinks of, and
Mm-hmm.
people were dying very quickly, including young, healthy people. So I think um, that's one where I think people recognize the pictures of the wards full of people with influenza. I was thinking back to the smallpox issue. I'm old enough that I had the smallpox vaccine. We actually stopped giving it in 1972.
Okay.
And that's because we weren't seeing any cases of smallpox in the US anymore. And it's the only disease we've ever eradicated with the use of vaccines. So this was a viral disease all around the world, that was eradicated purely with the use of vaccination. So I think that's a real success story. And I don't know that we'll ever see that again. I think that there's a lot more resistance to vaccines. And I suspect that some of that comes from being in a different world where if you grew up and you saw people with, your friends or your friends' children with polio, you'd be much more interested in the polio vaccine than if it's a disease you've never really witnessed.
Mm-hmm.
And I think things like tetanus, which is one of the most painful diseases I've ever seen, and I hope to never see that again. But I think if you've had that experience of seeing some of those things, then it changes your perception of what the risk versus benefit is of some of those vaccines.
I recently saw a video of a young man who he had to be strapped down because he contracted rabies from a dog bite and didn't get treated for it because he was against vaccination. He was against the treatment. He didn't want the drugs in his body, and it ultimately killed him. I mean, rabies is something that you cannot survive that unless you actually have the medication. That's
It's basically considered to be universally fatal. There's this one protocol that has been used, and I'm not sure how many times. I think it's called the Minnesota Protocol,
Mhm.
where it was the first time that they were able to get someone through rabies. But typically, what you would do is if someone had a bite, you give them both immune globulin around the site of the bite, and then also a vaccine to help them develop immunity. And
Mhm.
so, if you can kind of ward it off that way, you can prevent those outcomes. But it's generally thought to be universally fatal.
Jump back real quick. Two more questions from COVID-19. What lessons did we learn that we can apply to future pandemics?
Yeah, I think the hard place where we are right now is there's so many strong emotions around COVID-19, and that I feel like it's actually been maybe a little bit of a setback for public health rather than moving us forward.
Mm.
And I think we're all concerned that there will be, I think one of the things that people are keeping an eye on, and we don't know what will happen with it, but with avian influenza. So we're seeing it mostly in animal and bird populations, avian, meaning bird.
Mm-hmm.
But we are seeing some human cases. And right now, what we've seen in humans has generally been not a severe illness, but there have been people who've died from it. And one of the concerns there is that if an animal has both the avian influenza and a human influenza virus, and they swap some genes and create kind of a new virus, that could actually be a much more deadly kind of infection, and it would be one that
Mm.
we have not been vaccinated against, that are, we haven't been exposed to before. So I think that's part of the reason why people are watching that closely. But it's hard to predict what will happen with that,
Yeah.
and I don't think that we really know. And I think my default would be, if it's a new infection that I think is contagious, again, trying to, and at least until we figure things out, make sure
Mm-hmm.
that you keep your distance from from the people that are infected, or
Mm-hmm.
protect yourself when you're in close proximity to them, until we learn more about it.
Yeah.
And the other infection that I think has been in the news a lot recently is measles, which is the most contagious disease we have, and so one of the most contagious infectious diseases. And so, if somebody has measles and they're in a waiting room in an office, and you walk out of that room, but you've been coughing and sneezing in that room, someone else can walk in there and still pick up measles from that person. And
Oh,
so it's
wow.
really highly contagious. And so that's why there's been, I think, so much interest in measles recently.
Yeah. Oh, yeah. I've been watching that very closely. And I don't believe that I need to get the measles vaccination because I do believe I had it when I was younger.
You probably did. There was, if you're born before, I think it was 1957, you're assumed to be immune. And then there was a 5-year period between 1963 in 1967. So I guess 4-year period, a period there where the vaccine was not as effective. And so if someone was initially vaccinated then they would probably warrant, it would probably be beneficial to them to be revaccinated.
Okay.
But most people that were vaccinated after that time are protected. So you're young enough, you're fine.
Okay, good. Thank you.
I
I
fell into
think we
that
did.
category. So when I was in medical school, I was revaccinated.
Yeah. Okay. We did talk about that last time we talked on the phone. You were like, "Oh, you should be good," but it's important for people to know that and do your research and understand, what the pros and cons are. I always think that there is a pro to getting a vaccination. That's just me personally. I also don't have children, so that's a whole nother topic but you know, whenever we talk about the communities better preparing for the next infectious threat, to your point, there's a lot of sensitivity even around COVID-19 still. And there's a huge divide. So it's like, I don't even know if there's an answer to that question necessarily, but because some people still to this day don't think that COVID-19 was that big of a deal, but you and I can both speak to knowing people that died from it
Yeah.
and how
Yeah, and I think
quickly.
the other thing that happened is it really overwhelmed hospital resources.
Mm,
And so if you would have walked into a hospital at that time, um, there were a lot of things like elective surgeries were being canceled because the kind of the focus was on trying to not have people exposed to people with COVID-19 and trying to use the resources really for those sick patients with COVID-19. But we had many units in the hospital that were just people with this one infection. And so, I think being in the healthcare system and seeing how that was straining the resources, and I think that really the anger that came out around that was something that I think there are many reasons why many people left healthcare, but it created a huge nursing shortage. And I don't think I could be wrong about this. I don't think we've recovered from that yet.
mm.
And a lot of people that wanted to leave healthcare. And so I think we're still paying the price of that in many ways.
Yeah, absolutely. It has to be difficult to work in the field that you work in, going through something like that in real time. And a lot of people's mentality around doctors is they expect you to have the answer. And if you don't have the answer, to find it.
Yeah.
And
And,
do you feel
it's
like
hard.
that happens like quite
Yeah.
often?
I think it's hard with an emerging disease. And I think that science has come so far that people think that we would immediately know everything about a new disease when we first see it. And it really is still a process of learning and understanding it. And so, it went from, wearing masks outside because we thought that we needed to do that to recognizing that that was actually a place where that wasn't necessary. But if you're in a closed environment, then that
Mm-hmm.
risk would change. And so I think that the science can only move at a certain pace
Mm-hmm.
and the knowledge isn't going to be there immediately. And I think just having some respect for the fact that it will take time to understand it. And I think, if we would go back now and we're on day one of COVID-19, knowing everything that we know now, I think we would have done things a little bit differently. But I think that with what we knew at that time, that was probably, I think that the approach is usually no risk, and that's never going to be the final answer. Like I think you're always balancing risks and benefits with anything you do.
Mm-hmm. I do have one more question. What do you wish more people understood about the intersection of medicine, misinformation, and trust?
That's a great question and not an easy one. I think that one of the hard parts about our society right now is that there is a lot of misinformation out there, and I don't think that people are always able to recognize when something is misinformation.
Mm.
And I think then having that out there is part of what creates a lot of mistrust.
Mm-hmm.
And I would typically say if I'm looking for good resources, like if it comes to something with infectious diseases, I will go to like the Infectious Diseases Society of America website to look for information on certain illnesses. And historically, I've used like the CDC as kind of a referral for information on different topics that I feel like I need to know about. But I think it's a really difficult situation that we're in right now with just the lack of trust. And I don't know. I think that when it's a one-on-one situation and you're working with your physician one-on-one, I think that's very different from when there's someone that you don't know that's up on a stage and speaking, trying to figure out whether or not that's someone that you can trust.
Mm-hmm. It absolutely is an issue. I think it's a huge issue that we have right now. Even just headlines, right? A headline can just completely send someone down a rabbit hole or a path of that is fact. I follow an app called All Sides, and what they will do is they'll have three separate news sources for a specific story, topic, whatever it might be. And even just reading the different headlines from each one. So there's always one that's more to the right, one that's known to be more to the left, and then one that's a little bit more bipartisan in the middle. But the information in them even sometimes is different. And I'm like, wait, this one said this, but this one said it this way. So I'm taking it to believe that it's this. It's not what you say, it's how you say it, but that's the same for writing, how something can be written down. Yeah, I definitely think that it's a uphill battle, and I just really commend you for sticking it out. Obviously, you have dedicated, what, 4 decades, would you say?
So let me think. Well, I graduated from medical school in 1991,
Okay,
so that was
okay,
a long time
sorry.
ago.
You
And then 6 years of training after that. So after medical
you're like,
school,
don't you're like,
so
don't push
28,
me up there. You just
28
seem
years since then.
you seem like someone who was like, in your late teens, probably already understanding things and studying things. So I'm going back pretty far. I mean,
No, I was actually going to be a mathematician, and then I tried to decide on medicine at the last minute. But
well, that was the
um,
thing too. It's like, how did you know that you wanted to get into this field? And I know how you said when with your residencies, that's when you really start to figure out where you're going, right? But just getting into medical at all, I mean, so you went from wanting to go to school to be a mathematician, and then you were like, I'm gonna go to medical school instead. You just
Well,
like,
actually, I was one of those kids that like changed their major like every other semester in college. So I started off in
okay.
math, and then I had roommates that were studying microbiology, and I thought, well, that's interesting.
Mm-hmm.
So um, it wasn't until I was going into my senior year. So everyone usually takes the MCATs their junior year. The summer going into my senior year, I decided I was going to go to medical school. So then I started studying for the MCATs that summer. So I took them a little bit late, but it was. I think I landed where I wanted to be. I actually love this job, and it can be sometimes the hours can be long, but I really love what I'm doing. And I think part of what made me decide to go into medicine was that I was afraid I was going to sit in a cubicle and never talk to anybody.
Mm.
And I really like people and interacting with people. So that suits me. And also, I couldn't have a desk job because I can't sit still. So
Oh, same.
that's the other beauty of this job.
Yes, I'm exactly the same as you. I watch. I'm a Grey's Anatomy fan, right? Do you watch any like medical shows or anything? I just
So
watched The Pit. Have you heard of
I
that?
love The Pit.
I love
I
The Pit.
have to admit that Grey's Anatomy is a guilty pleasure. It's not what it's really like.
Okay. Okay. Okay.
Just so you know, it's
Yes.
not real life,
Yeah.
real life. But it actually does help me just relax. And I think um, I think that The Pit I liked because it felt more realistic,
Hmm.
and I also just liked how they delved into the personalities.
Well, what I love about The Pit is that it's a whole entire season broken down over one day. And you
Yeah.
see how much goes on in one day in the emergency room. And obviously I loved it because it's in Pittsburgh. It's based out of Pittsburgh, and they don't ever leave that area, but you're so engaged. You're so engaged in all of these what feel like real situations that were coming in and that they were dealing with, and topics that we need to be talking about, conversations that we need to be having. And if you're going to go to a hospital and ask for care from a doctor, you do need to trust that they have your best interest, that they are there to help you. I think when it comes down to, I say this a lot, that there are really good people in this world and there are bad people in this world. And I ultimately meet people where they're at. When I first meet them, I don't make any assumptions about what their intentions are unless they show me otherwise. If they start to show me that their intentions are poor, then I act accordingly. If I realize someone is not truthful or whatever it might be. But when it comes to medical doctors, like when I go to the hospital, I don't question anything that they're doing. Be as open and as honest as you can. Is there anything that you would like to say that you haven't said? I know I've been kind of like going here, and there and all over, but
Yeah.
I'm just so fascinated with what you do. And I think one of the things that I want people to know about Karin is, she's not on video, but she's always smiling. She always seems just so pleasant and happy, and you seem light to me. Would you, you know, what do you attest that to? I mean, you have an amazing husband. You typically come in together, and I don't know, what would you attest your overall just really positive attitude to?
Well, that's a hard question to ask. I think I tend to be an optimist, and I also have, I have a very good life. I've got a wonderful husband. I've got, good friends, and we go to places with wonderful food, and usually see me there.
Mm-hmm.
So, I think that there are a lot of good things in my life. And the one other thing that I was thinking about when you were talking about that you hope that doctors have your best interest at heart, I was actually thinking about when I'm in the hospital and I'm listening to the medical students and the residents, on rounds, and hearing them all trying really hard to understand things, and all trying to work together to figure out like what is the best thing to do for this person. And you hear them discussing it out loud because they're in training and they're trying to understand everything. And I think that when I listen to all of these people that are the future of medicine, it's so inspiring, because I think these are people that really care, that are really dedicated, and do have the patient's best interest at heart, and they're trying to learn how to do it to the best of their ability. And so that's actually, I think, one thing that I see at work all of the time that really gives me, I think, hope for the future of this field.
Well, thank you. You're amazing. I'm so fortunate to know you and for our lives to have crossed paths. And this was an impromptu conversation. So I just I think you're amazing, and I'm so glad to call you a friend and an expert. We will have to dig in sometime, and I know I mentioned this to you once, but when I had my extended genetic testing, is it Myers? Is that what it was? What's the Merrick? No, maybe not.
I don't remember which testing you had, but I do remember the conversation though.
Salad disease. I guess it's referred to as SD, and I think it's neurological. And typically, if someone carries it, you don't have any symptom. You can carry it, not have symptoms, right? But it was when I was going through the donor process with, wanting to have a baby. If my donor had it, then the chance of my child having it would have been probably about 100%. If they had it, then it would have been two halves coming together and making a whole. It's very fascinating to me. I didn't even know, and I don't know if there's anything that I could be predisposed to because of that. Does that make sense?
Yeah, and it's not a disease I'm not familiar with.
Yeah,
I did look it up when you told me about it,
mm-hmm.
and typically, if it's something where you've got two different genes, so if it's not, if you can be a carrier or not express the disease,
Mm-hmm.
then you would have had to have inherited the one that carries it from both of your parents. So it wouldn't guarantee that a child would have it. But if they got the wrong gene from each parent, then typically that would be what would cause disease.
Okay. Yeah. It was interesting when that came back, and it was like, you do have something. And I'm like, wait, what's going on? That's wild. So
the other thing is, if you look for enough things, you'll find something that's abnormal. And then the question in medicine is often like, when is this significant or not?
mm-hmm.
And sometimes we even worry about, and I realize I'm probably going over a little bit, but just kind of tracking down if there's an abnormality that's probably insignificant, but now that you know about it, then sometimes it results in a lot of additional tests, which might actually not end up being necessary in the end when it turns out to be what you thought it was initially. But because you've seen something abnormal, then you feel like you need to get to the bottom of it.
Mm-hmm. Yeah, of course. Well, thank you. I really appreciate you. I know you were on call today, and you have friends, so I want to let you. We took an hour. We're a little over, but I really appreciate you and just your expertise, and thank you so much. So, and I hope to see you soon.
Nice talking to you.
Yeah, you too. Thank you for tuning in to this episode of the Alter Ego Podcast, produced at the Butler Eagle right here in Butler, Pennsylvania. Be sure to subscribe on the Butler Eagle YouTube channel and rate and review us on your favorite podcast platform. It really helps others to find the show. Next week on the podcast, Dr. Amesh Adalja, infectious disease expert and recent distinguished graduate honoree at Butler High School, joins us to talk about emerging health threats, pandemic preparedness, and what it means to be recognized in his hometown. You won't want to miss it. Until next time, stay safe, stay hopeful, stay kind.